I'm one of the pediatric orthopedic surgeons at Children's Memorial Hermann Hospital, UT Physicians Group. And with the help of Nathaniel Hunter, one of our medical students, we were able to put this video together to help you understand the nature and specifics about your child's fracture. The agenda for this video is to cover general concepts related to supracondylar humerus fractures, risks and benefits of treatment, a follow-up plan, and also contact info to get in touch with our offices if needed in the follow-up period. Kids are not small adults. Children present with unique pathology of their own. They require a different approach to treatment than adults. There's unique challenges specific to children, and there's different goals of treatment. One of the different goals of treatment is getting the fracture set as close to what it was before, but it doesn't need to be perfect. If we can get it about 90% of the way there, the child's body will be able to remodel or realign the bone and make it normal in time. We want to use minimally invasive techniques, such as pins and a combination of splints and casts, instead of using big hardware methods such as screws and plates that adults may need in their fracture patterns. We also want to decrease the OR time if at all possible, but obviously we'll take as much time as is needed to treat the child appropriately. And while the child is asleep, we take advantage of them being sedated to place a perfect cast or splint to allow to supplement the tools that are used to set the fracture right. This right here is a picture of a supracondylar humerus fracture. As you can see, there is a slight deformity to the arm, and you can see in the x-ray how evident it is that there is a fracture of the bone and two main large pieces. Your child may have suffered a similar fracture. To give you an idea of what a supracondylar humerus fracture is it's a fracture in the supracondylar region of the humerus. This is the humerus bone, and think of it as the top of the elbow. And the fracture happens right at this place as it transitions from one bone to the other down here. This is a side view looking at the fracture, and you can see there's three types of typical fracture patterns. One where there's a break, but there's no separation of the bones. One where there's a break, but there's a little bit of contact. And a third, which is probably one of the more common types that we see in our practice as a level 1 trauma center, where the bones are completely separated. When we set the fracture, we typically use 3 to 4 pins in appropriate configurations. Then we check the stability while the child is asleep, and we place a splint to hold it once the pins are in place. More unstable fractures sometimes will require a small opening to line up the bones under direct visualization. This is not common, usually only done in about 2% of all fractures that we see, but sometimes it's necessary if there's something blocking the bones from being set. And the pins will be removed in the office at about 3 to 4 weeks depending on the age of the patient and the healing rate. You can see here, this is an after picture of one of our patients where the pins are in the appropriate trajectory and they're holding the bones in place. This is just a drawing of the same thing. You can see these pins are spread in a specific configuration to hold the fracture in place. Risks with this type of injury. So vascular injuries or injuries to blood vessels, very uncommon, but it is sometimes seen in the more severe fracture types. And if that's the case, we will treat it accordingly and fix the problem. Compartment syndrome. This is a rare condition where from the injury itself, you can develop pressures in the arm associated with the fracture, and that will require a repeat visit to the OR to release the tension in the pressure areas. Infection, also very rare, but can sometimes happen, especially when these pins are entering the skin. Sometimes bacteria can get into the area, and it won't be noted right away. It's usually noted on follow-up visits with fevers, etc., but it's treatable very easily. In the most extreme cases, the pins have to be removed, but it's very unlikely for this to happen as children tend to have low infection rates. Nerve injury. With the initial injury, when the bones break, sometimes nerves in the area of the elbow can get stretched, and this can present in your child not being able to move the fingers in a certain position. But these tend to always recover. Now, it's not 100%, but most of the time we do tend to see recovery. And need for repeat procedures. In really bad fractures, even if the initial treatment is rendered, sometimes additional procedures are necessary to make the fracture perfect. And then the risks with anesthesia. Whenever a child goes under anesthesia, especially for the first time, it's unknown how they will react to it. But in a center like ours, where we have excellent, exceptional pediatric anesthesia colleagues, they're able to treat any situation that comes. And also can't see all possible complications. The main thing is being set up with someone or a team that knows how to deal with anything that comes your way. So always expect unforeseen complications. Though rare, we're always ready to take care of it. In terms of your postoperative plan for your child, you're going to follow up in 1 week from the date of surgery, give or take. Then you're going to change the splint to a cast at that 1 week follow-up. Some practitioners will just overwrap where they put a cast material over the splint that's existing, but that's done at the 1 week follow-up. Then you're going to follow up again at 3 to 4 weeks from the date of surgery, and at this time the pins will be removed. That's called the pin removal appointment. So in terms of pain management after surgery, elevate the arm in a splint on pillows at or above the heart height. You want to do a minimum of 8 hours a day for the first 5 days, and that really helps with not only pain, but also with healing. You want to do over-the-counter Tylenol and Motrin, and you want to alternate this every 4 hours. This is very effective for pain management. We're trying to move away from using narcotics in our children, and it really helps to just do the Tylenol and Motrin every 4 hours, alternating, and do that for the first 3 to 4 days. Then after the first 3 to 4 days, you're going to use Tylenol as needed. Things to note. So splint and the cast must be kept dry as possible. Sponge baths to avoid the splint, especially the initial one, from getting wet. If it does get wet, please contact us to help arrange for an immediate changing of that, because we don't want those pins to sit in a wet environment. Pain is normal post-operative, okay, and post this type of injury. But it always gets better by about 7 days. But you have to weather the storm a bit. The Tylenol and Motrin will help, but it won't take all the pain away, but it will get better, I promise you. And fevers are normal to have for your child for up to 5 days after surgery. So pin removal. It's very easy. It takes about 1 to 2 seconds per pin. It's normal to have some bleeding once the pins are removed. And it's normal for a child to have fear, because this is all new to them. They don't know what to expect, especially the younger patients. But it's over before they know it. So we try to work fast just to avoid them from having consistent apprehension. And then we don't do any anesthesia or injection. It's so quick to get the pins pulled. Doing an injection or some sort of anesthetic would actually be not only risky, but it would just add more time. And it's normal for the child to have pain and soreness after removing the pins. And that's not from the pins, it's actually from being in the cast for several weeks. Just the joint gets stiff, and the child may perceive it as pin-related pain, but it's actually just stiffness from being in the cast, and that tends to unwind itself over the follow-up periods. Recovery process: when the pins are pulled, the patient's allowed to move the arm like normal, or as close to normal as they're able to. It can take, however, as much as 6 months for full recovery of motion. Okay, very rarely some patients may not able to regain the full motion of the elbow, but almost everyone that we see does. But it can take as much as 6 months, but it's usually faster. Any nerve injuries can take as much as 6 months to 1 year to fully recover. Okay, so that's something you have to be very patient about. But we do tend to see a longer time frame for those to recover fully, but it gets better and better with each visit and follow-up. And in some cases, depending on how severe the injury is, the age of the patient, will recommend formal physical therapy. So our team, we have 8 pediatric board-certified orthopedic surgeons. We're a level 1 trauma center, so this is the highest level trauma designation. So we deal with the most worst injuries you could imagine on a daily basis. We have an excellent OR care team and staff that's very well trained and knows how to manage this type of patient population. And we have an excellent outpatient clinical care team that deals with these type of fractures on a day-to-day basis as well. We're a teaching institution. We work with residents and fellows, and they're closely involved with your child's care. And we're all trauma experts in our team, and I promise you your child is in excellent hands. This is our contact info. And thank you so much for trusting us with your child's care.